I would like now to welcome our fifth speaker, Louise Roed Rasmussen, the past chair of the SOE Young Ophthalmologists, who is working in Copenhagen and who will discuss a suggestion for a minimum surgical curriculum in the European Union. Please.
Good afternoon. My name is Louise Rasmussen. I'm past SOE chair, and I will present a suggestion for minimum surgical curriculum within the European Union. First of all, I couldn't have done this without any of my friends. This is the SOE steering committee made back in 2018 with the purpose of making a surgical minimum curriculum. The first question we asked ourselves is, what are we training to become? And the most basic definition is that we are training to become general ophthalmologists. So we made a definition of that. That's a comprehensive ophthalmologist that can take care of the majority of patients with all types of eye diseases who is met in the general population, including minor surgery. That means that you can take responsibility on calls, you can work at a smaller hospital, you can work in private practice and do things independently. The subspecialist is another game. Why is this a problem? It's a problem because we live in the European Union, where there's a free movement of travel across European borders, and that aims for some sort of harmonization. This was recognized by the European Union many years ago, and they created the UEMS, the European Union of Medical Specialists, with the purpose of aiming harmonization in residence training, but also with the goal to create a European training requirements called the ETR. This has already been completed by more than 50 medical and surgical subspecialties. There is a UEMS for all medical specialties. However, the ETR for ophthalmology is still in the process. You can't say that they have been sleeping, but because they have created the EBO, and the EPO is harmonizing the theoretical foundation within residency training, and it actually has improved a lot, and now it has a curriculum. And they are testing the theoretical level even on complicated surgery. But we do not have a surgical curriculum within the European Union. So this is our suggestion, from the perspective that all residents should have a fair chance to get this basic introduction to be able to take care of most ophthalmic patients and become general ophthalmologist. And all on minimum numbers. If you feel for training your residents even more intensively, just feel free to do so. Please do. We choose the procedures from 5 different aspects. Disease prevalence, it needs to be a frequent disease or procedure. Is it safe to train for the patient if the resident is doing the procedure? What is the case trainee ratio? How many cases are there available? And how many do you need to do to be confident? Some skills are taken into account because they have a huge amount of skill transfer. And some are left behind because they are technical difficult, which means that you need to practice a lot of time to gain the competence. Finally, we needed to define the training definitions. We aim for full competence, but in the procedures where we are measuring numbers is for primary surgeon, and that is defined as a resident that must be presented to all critical steps and perform the majority of the critical portion of the procedure under appropriate faculty supervision. The last thing is quite important, mainly for safety of the patient, but also for the learning possibilities. The lowest level is assisting, and we should avoid observing. We made different categories, and this is the first one in our suggesting, which is on laser procedures. And we aim for full competence in capsulotomy and in all retinal laser therapy except for diabetic focal laser treatment. Everyone should have some experience with iridectomy and SLT. For injections, all should have full competence in intravitreal injections. In anterior segment, corneal foreign body removal and removal of corneal sutures should be standard. Some will even not regard this as surgical procedures. Everyone should try to remove simple pterygiums, no complicated cornea procedures, but basic phaco. And with 50, we know that we are not aiming for full competence. You should have at least 250 if you are aiming for something like that. But with 50, we give the residents a fundamental insight into this procedure, sending the right patients for surgery, giving good post-operative care, and have a basic to build on if they want to become a competent phaco surgeon in the end. So that is the proposal. For the external oculoplastic, there is a lot of smaller procedures, suturing of small wounds, simple eyelid laceration, biopsies, shaving excision, lashes, chalations, dacryocystitis. For the more, but still basic oculoplastic surgery, we think there's a huge amount of skill transfer between the various procedures. So we aim for around 50. And it doesn't really matter if you do a lot of blepharoplasty or you do a lot of tarsal sling, but you need to have some skills where you can feel the tissue and become competent in suturing within that area. Also knowing when it's not simple and easy. No lacrimal surgery, except for punctal occlusion. In the end, basic strabismology we suggest 10 procedures, and that's mainly because in many areas of Europe, it's the residents and fellows who have the on-calls where they are need to take care of the globe ruptures. And basic strabismologists have a skill transfer to move around the globe and to handle globe ruptures and get more experience in that field. How controversial is this? It is on European basic quite controversial. But if you take a perspective out in the broader part of the world, it's not that complicated. If we compare this suggestion to the ECO, the All India, US, Canadian, Pan America, or Royal College, you can see on this slide, if we compare the numbers, and I'm sorry, it's a bit crowded slide, that our numbers, which are out here in the last den, are quite low and quite in line with the other supranational and national societies. FC is full competence. So in conclusion, creation of European training requirements for ophthalmology, including minimum surgical standards, should be completed. And this is a suggestion for the surgical part. We are all training to become general ophthalmologists, and our residency training should fulfill that goal.
Many thanks, Mary-Louise, for showing us the possible pathway to harmonize ophthalmology training in Europe. We will have the chance to discuss your presentation at the end of the webinar.